All right. Thank you, everybody. As I mentioned, today we're reviewing regulations of digital health, and we're focusing on information blocking and the health breach notification law. These are under two different agencies, and they're relevant to a lot of consumer-focused digital health products because, depending on how you classify yourself as either being a covered entity or not, you might be on one side or the other. It's a very nuanced topic, and Mike has done a very detailed job of laying it out in his slides. Mike, I'm going to go ahead and stop sharing and then let you take it away.
All right, great. I actually just shared my screen, so could you see the PowerPoint slide? Perfect.
Good to go.
All right, thanks, Ryan. Again, everyone, thanks for joining today, and especially those who came last time. I hope you find this lecture to be as helpful as well. My name is Mike Martinelli, as Ryan just said, and I'm head of government here at Standard Care. And today is the second installment of a two-part lecture series on regulations for digital health. Today we'll be focusing on the information blocking rule and the FTC's health breach notification rule. So just to briefly recap the last webinar lecture. We covered technology for the use of transmitting and managing health data, and we use that as a way to just discuss the general definition of health data as it's defined by federal healthcare regulations. And the reason that we started off that way is because throughout this lecture, different regulations have their own nuanced definitions of health data. They get more specific. So for those of you who remember from last lecture or who are familiar with HIPAA, the health information that's regulated under HIPAA is called PHI, Protected Health Information. And that has different components, different aspects to it that aren't, simply that don't just fit the general definition of health data. And we'll see that as we go throughout this lecture, how that's a recurring theme. So the overall outline for this lecture, like I said, we're going to talk about the breach notification rule and the information blocking law. So the first regulation today here is the health breach notification rule. It's abbreviated HBNR, so that's what I'll be using when I refer to it. And this is different in the sense that it's enforced by the FTC. So far, all we've been discussing, all the regulations we've discussed have been enforced by HHS, whether it's OCR or another sub-agency within the U.S. Department of Health and Human Services. So the HBNR, this is a rule that regulates health data. Again, going back to that original overarching definition of health data, the specific type of health data that's regulated under the HBNR is called a personal health record, abbreviated PHR. And this is important because this is health data that is not regulated under HIPAA, because the data contained within a PHR does not satisfy the legal criteria or the elements for PHI as established under HIPAA. So this rule requires that PHR vendors notify consumers following the breach of unsecured data. So what the PHR vendor is that those are the actors who have the PHR and are using it in whether it's their digital health app, whatever technology they're using that has health data that specifically fits the definition of personal health record. So if you're dealing with PHR, then you're a PHR vendor. So these PHR vendors, like the thing about this rule that's different from a lot of the other rules is that it requires you to take an action only when a adverse event occurs, specifically a data breach. So I want to emphasize the fact that a data breach under the HBNR is not a data breach under the HIPAA security rule. So if you recall from the previous lecture, and I'll send out slides from that lecture as well on HIPAA, a breach of PHI, electronic health information, like from a hospital under the HIPAA security rule, is its own data breach. Under the HBNR, this is not the same. And the reason for that is because the HBNR regulates personal health records, which are not PHI under HIPAA. So they're regulating two different types of health information. So the rule itself here. So when a PHR vendor must issue a breach notification, it must satisfy certain requirements. First, there's a method by which it must be issued. Second, there's a time as to when it must be issued. This is done by like saying a PHR vendor realized or had a data breach on like, Monday, and they have 30 days, a 30-day time frame in order to send out that breach notification. And it also sets criteria for the content that must be included in that notification, such as the nature of the data that was compromised in a breach, also like the time span of data. So say the data was, so say you had a health app that collects, heart rate monitoring data, weight, BMI, and it has it's been collected for over several years just to in order for the patient to look at their health trends. The content could also mean a few things. It could be that the breach only affected the weight data on the health app, and or the time frame of when that health data was on the app. So by that I mean the breach only compromised health data pertaining to weight values, BMIs, from March 1st, 2020 to April 1st, 2020. So the content could also mean the time period of the data that was compromised. Another important note here is that when the data breach affects 500 or more consumers, the PHR vendors must issue a notice to the media. So that's essentially what that means, is it's a public notice, because so they use the word 500, might be somewhat arbitrary, but that's at the point where when you go beyond 500 consumers, sending individual notifications out to each would be logistically infeasible and unlikely to be able to be completed within the proper time frame. And that's especially for data breaches that affect thousands of consumers. So what exactly is PHR here? So we'll see what this is and then see how it differs from PHI and HIPAA. So the PHR is an electronic record of identifiable health information on an individual that can be drawn from multiple sources. It is managed, 1, shared, 2, and 3, controlled by or either primarily for the individual. So let's use the example of, say, our Apple Health app, if you have an iPhone, you can input your own values for BMI in there. You could decide whether or not you want to share it because you can control it. Um, or if it's for a minor, so say it's a parent who's collecting this data for their minor, it's being controlled primarily for an individual. So the important thing here to keep in mind about PHR data is that it's like the individual is the one who has control over the data, and they're the ones that are putting the data into this health record. And there's two types of PHRs. The first is a standalone. So here, the patients enter their own health information in their own from their own records, and they store it in like computers, smartphones, like the Apple Health app, or through the internet, some kind of patient portal or something that's not related to a healthcare provider. In some instances, standalone PHR can accept data from external sources, such as like vitals, data from a doctor's visit, and lab results, like such as testing. The way that would happen is that you give permission to link your so I'll use an example that pertains to me. I have Apple Health and I synced it with my Penn Medicine, which is my healthcare provider's. It's the patient-facing health app. So whenever I have vitals taken, they are synced to the MyChart app, and I can give permission, individual permission, to allow MyChart to transfer that information into Apple Health, so I could look at it, like have it all in one spot and like view my trends. And if I have information from other sources, I could add it in there as well. So the thing here for a standalone PHR is that the patient is allowing for that information to be stored in their own health app. And then this one is pretty much kind of what I was inferring earlier. Patients may also like personally enter information into an app. So I could just manually enter my weight into a health app, or my heart rate, or whatever. And that's really comes to the heart of what a PHR is that patients can decide whether to share the information with providers, family members, or anyone else involved in your care. So that's that recurring theme, is that patients have the control over it. The second one is tethered or connected PHRs, which is slightly different. So this is where the PHR is linked to a specific healthcare organization's EHR system, or to a health plan's information system, so that patients can access their own records through a secure portal. So say that I have the Apple Health app, and it's linked to MyChart, my Penn Medicine, which has all my records from the Epic system stored on there that I can access. If there's a secure portal in the MyCare app that can transmit the data to Apple Health, the patients can access. So patients could go on to Apple Health and view the records from like the MyChart app without going on that app, if that makes sense. You could go onto the EMR app yourself and look at the data, or you could go securely through Apple Health and view that data. it's still a PHR because the consumer like when they're viewing it in Apple Health, they have control as to whether or not they could delete it from the Apple Health app, share it, or keep it for their own record. So that's why it wouldn't be PHI, even though it's synced with an EMR app. So here's a sample scenario where I'm comparing PHR to PHI. So basically, we're comparing HBNR to HIPAA. So here we have Beast Mode Health, which is a smartphone fitness app, and it tracks, collects, and records heart rate, blood pressure, weight, BMI from its consumers. So Beast Mode Health collects the same vitals data as healthcare providers would in a clinical setting. When you go to your annual checkup, you get, blood pressure, heart rate, weight taken. Usually that's the general procedure when you have a primary care visit. However, the kicker here is that the data is not collected by a healthcare provider through the course of carrying out treatment. The second part, if that data, that same vitals data that was collected by Beast Mode Health was collected in the course of carrying out treatment by a healthcare provider during a practice visit, it would be PHI. But because Beast Mode Health, that app, collected the data for the sole purpose of the patient's use, it's not PHI, it's PHR. And this highlights the different characteristics of the entities and data subject to regulation under the HBNR and HIPAA. So here, Beast Mode Health would be the PHR vendor, and the data collected by Beast Mode Health would be the PHR. So that's all I have for the FTC's HBNR rule. The next part of the lecture, this is going to be a little bit more in depth and is going to constitute the majority of the lecture. So if anyone has questions during this portion of the webinar specifically, feel free to shoot Ryan a message in the chat.
Yeah, and we'll pause there a second. So this is an interesting distinction because a lot of the information blocking laws that Mike is about to talk about only apply to covered entity. A covered entity is jargon for somebody who is providing medical practice and doing interstate commerce by charging for it. It's usually through federal, Medicare, Medicaid. So we would think of them as doctors, and then their business associates who are processing those claims and whatnot. So a lot of fitness apps, some mental health apps are taking similar information, but may not be handling it at the same level of care, and do not have the same obligations to then share that data across, back to your primary care provider or future providers, or back to your personal health record or whatever. So this is a key distinction that a lot of companies and founders try to navigate by avoiding, sticking with like a wellness label on the product, and then avoiding the heavier regulations for information blocking that we're going to get into next. Are there any questions while we have a break here? Going once, going twice. All right. Thanks, Mike. Take it away.
So next, we have the information blocking law. This is pretty recent. It was part of the 21st Century Cures Act. And guidance is still being issued by the regulatory agencies because it's so new. But this lecture, my goal is to cover all the important fundamental aspects of the blocking law so that when newer guidance comes out, you have a good foundation for understanding the blocking law. And this is enforced by HHS. A lot of times you'll see materials issued by the ONC, which is the Office of the National Coordinator. They don't enforce the information blocking law, but the Office of the National Coordinator is involved in many aspects of digital health and any type of healthcare um, processes or programs within the federal government, mainly HHS, that involve digital transmission of health data and health IT. So it's important. I felt it was important to give a brief review of relevant HIPAA provisions from the last lecture, but I shortened them a bit because these are very relevant to what we'll be seeing later on when we talk about exceptions to this rule. So I didn't go into as much detail as I did previously. So if anyone has any questions on the HIPAA slide, the HIPAA review slides, please feel free to ask, because it's important to recall these as we progress through the lecture. So first, the entities regulated under HIPAA are covered entity. These are entities that could be classified under one of three categories: healthcare providers, health plans, and healthcare clearinghouses. The second is a business associate. This is an entity that performs certain functions or activities on behalf of a covered entity that involves the use or disclosure of PHI. And an example of this would be contractors or subcontractors. So a covered entity, a CE, needs to contract out a business associate to fulfill certain functions that the CE is unable to perform. For example, billing and payment. Medical billing involves diagnostic codes, which would constitute PHI. So a business associate would need to receive PHI in order to fulfill that function for the CE. And that's essentially a contractor relationship. Now we get into protected health information. This is the important part here in terms of the type of health data HIPAA regulates. So first, the first prong here is that it's individually identifiable information. And I'm going to give you what it excludes and includes. It includes that a PHI transmitted or maintained in electronic media. So that would be electronic PHI or ePHI, and that of which is transmitted in any other form. So what this means here is that PHI could be both electronic or paper, usually paper, like a paper binder with medical records. What it doesn't include is education records covered under FERPA, which is the education privacy law. And that would involve instances with like university student health and counseling services. Also not included are employment records held by a covered entity while acting as its role as an employer. So a hospital's employee injured themselves while working, and they went to the hospital, that same hospital to receive treatment. The records for workers' comp, the medical records that they would use for the workers' compensation would not be PHI because it's not used for healthcare purposes. And then the last one is if you did have a set of PHI for an individual, but they were deceased for over 50 years, it's no longer PHI. And that's just a matter of, logistics. You can't expect healthcare organizations to just collect and maintain every single health record of everyone they've seen. So 50 years seems like an adequate amount of time so that, seeing that information wouldn't violate anyone's confidentiality. And now we have a designated record set. So this is really building up to the type of health data we're going to discuss for the blocking law. And this is a group of records that are maintained either by or for a CE. And they include medical records and billing records about patients. And these would be maintained by healthcare providers. The next are enrollment, payment, claims adjudication, and case or medical management record systems. So what this is these are record sets that are maintained by a health plan. So like a insurance, health insurance company, they would have this type of data in their medical record system, because in order to pay out a claim, they need to, have a case or file on an individual with the surgeries or medical treatments they used. The last would be any other records that are used either in whole or in part by the covered entity to make decisions, such as diagnostic or treatment decisions about individuals. So this would be more of a catch-all. So if it doesn't fit into one of the first two categories, if there's records that are used by a CE, say a physician, to make diagnostic treatment decisions about a patient, that would be part of the designated record set. So I thought it'd be important to really give some clarification on the term record. So the record is any item, collection, or grouping of information that contains PHI, which is maintained, collected, and used or disseminated either by a CE or either by or for a CE. So the record is just that grouping of information of PHI that the CE can do, maintain it, collect it, disseminate it. Next is the use and disclosure of PHI. So this is important because I'm sure many of you, if you've went to a physician for treatment, first visit, you get this HIPAA packet and when you sign that, you're giving HIPAA consent. And that consent is for the CE or the physician's practice to use or disclose a patient's PHI. However, so that's a general rule. They must always obtain consent to use or disclose PHI, someone's PHI, except when the CE is carrying out one of these three following functions: patient treatment, billing and payment, and healthcare operations. So for patient treatment, if you went to your family practitioner and they couldn't figure out what you had, a rare illness, and they couldn't come up with a diagnosis, or they needed a specialist to look at some imaging studies. So, they would not need your consent to disclose that information. So say that imaging study to a radiologist in order to carry out the patient's treatment, because it's all part of the treatment, and it would be it would be overly burdensome every time a physician has to obtain consent to, share their patient's information with another physician in order to treat them. That would just be, literally impossible. Same with billing and payment, because billing and payment involves diagnostic and treatment codes, which is PHI, and you can't expect billing departments to continually call and obtain consent from patients in order to process their bills, or otherwise the patients would refuse to give consent because they wouldn't want to pay, obviously, for expensive healthcare. So That's for billing and payment, and healthcare operations is a catch-all. Anything else that's involved in the process of carrying out the overall operations of healthcare, that would fall under this exception. All right, now to the information blocking law, which actors are regulated and what type of data is regulated. So the four categories of actors that are regulated under information blocking is one, developers of certified health IT, health information exchanges, health information networks, and healthcare providers. For the last one, number 4, and number 2 to some extent, are the most common ones you'll see, especially in the examples that we'll be giving later in this lecture. So now we have electronic health information. This is the type of health data that is regulated under the information blocking law. And it's very similar to PHI, but not quite. And we'll see why. So EHI, electronic health information, is ePHI, which is electronic PHI, to the extent that it would be included in that designated record set, regardless of whether those records are used or maintained for or by a CE under HIPAA. EHI does not include psychotherapy notes or other information compiled in reasonable anticipation of a legal proceeding. And this is also consistent with HIPAA because PHI does not include psychotherapy notes or information compiled in the anticipation of a legal proceeding. The legal proceeding part, that's common throughout, like any federal law that involves like data, whether it's health data or any type of data transmission. There's always a exception for legal proceedings. Psychotherapy notes have their own treatment under HIPAA. And I think I went into that in the previous lecture. So here's a chart to help. I hope this isn't too confusing, but I thought it helps best visualize the relationship between EHI and then PHI, protected health information. So this large box, the all-encompassing box here, this is your PHI, that dark blue rectangle. Within PHI is your electronic PHI. So that's your protected health information that's just in electronic form, not in paper form. So now we see a yellow dotted line here, and this indicates what constitutes the designated record set. So the designated record set does include, see, it goes beyond the EHI box to PHI, but the EHI, if you see right here, what I have highlighted in red, only constitutes all EHI that all electronic PHI that is in the DRS. So if it's part of a DRS that is not electronic, that would not be EHI, because paper is not electronic, it's not digital. Here you see this EHI is also USCDI V1. I'm not going to get into that. We're talking about possibly getting into this in a future lecture, but for the purposes of this, because this section in the green, the USCDI1, falls within the larger category of EHI, as long as you know that EHI consists of all electronic PHI in the designated record set, you're good, because that would also include what's in this green sub box, the USCDI V1. So here we have the actual definition, legal definition of the information blocking law. And what it is that it's any practice in which an actor, one of those four actors I discussed in the previous slide, when they engage in a practice that will likely interfere with the access, exchange, or use of electronic health information. So by interfering with access, exchange, or use, that would be blocking. The exceptions, because every single law has exceptions to it, is one, when a practice is required by law. So if another law requires you to withhold certain information, then this practice would not constitute information blocking. And we'll see that in some of the exceptions, which is kind of redundant here because this law lays out practices that could fall within one of 8 exceptions in the statute. So some laws are written in a way that they give a broad like prohibition on something. So here it's information blocking, but instead of like trying to figure out every instance where it's allowed, it makes much more sense. It's much more efficient to carve out the instances where information blocking would not be illegal. And this is the heart of the lecture here. There's 8 exceptions to this. So the 8 exceptions to the information blocking law here. This is the next section. So the first 5 we have is the preventing harm exception, privacy exception, security exception, and feasibility exception, and health IT performance exception. And these first 5 are exceptions where they straight up permit the blocking of access, exchange, or use of EHI. This is where the actual act of blocking it is permissible. The next 3 are slightly different. The content and manner exception, the fees exception, and the licensing exception. They're not outright blocking the exchange of EHI, but they cover procedures by which actors must fulfill requests to access the exchange, use, or EHI. So what that means is that there's some obstacle or hindrance that must be, there's some obstacle in the way, or which must be overcome in order for the information exchange to occur. And this is best exemplified in the fees exception. So like, I'll briefly, go over that. So say an actor requests a set of EHI from a hospital, and the hospital charges a fee in order to fulfill that request. As long as the fee is reasonable and it's fits within the conditions of the exception, that would not be information blocking. Because if you look at it just like on its face, charging a fee in order to exchange information would be in essence blocking the free exchange of that information by putting like an obstacle in the way. But there are instances where that is permissible. So here we have the first exception. It's called the preventing harm exception. And the overall objective here is that given the public interest in protecting individuals against reasonable risks of harm, the practices are likely to interfere with the access, exchange of use, or EHI are justified under a few circumstances. 1, there is a reasonable belief that the practice will significantly reduce the risk of harm. So the practice of blocking exchange of that EHI would reduce risk of harm. Also, the practice must not be broader than is necessary to achieve the reduced risk of harm. The practice must also provide each patient the right to request a review of an individualized determination of the risk of harm. And last, the practice must satisfy one condition of these categories. And they must be like a satisfied condition for type of risk, type of harm, and the basis of implementation. So because these slides on the exceptions are a little bit more detailed and not as easy to grasp when you first learn about them, Ryan and I are going to do a little, form a little example of a scenario where this would play out. So Ryan, if you want to come back in and do this hypo.
Of course, this is the
Preventing harm exception.
this example I think is with Dr. Alice, which I think is
Oh,
you.
yeah. Okay, yeah, I'll just do this one myself. That's a good point. So an example of this here, say you have Dr. Alice, a psychiatrist, and she's been treating Bob over the past year. Bob suffers from suicidal ideations, which she, Dr. Alice, has recorded in Bob's medical record as clinical evaluations relating to his diagnosis. So important note here is that Dr. Alice is a psychiatrist, which is a medical doctor, not to get that confused with a psychologist. So they can make clinical assessments and prescribe medications, which would have a medical record set separate from psychotherapy notes. So she has recorded, made clinical observations of this and included it in Bob's record. Bob is extremely concerned and under immense pressure regarding the fact that he received psychiatric treatment and that others may find out, particularly, especially regarding his suicidal ideations. So he's very, under immense pressure and stress that someone may find out that he's receiving treatment, especially for the suicidal component. During Bob's annual wellness visit with his primary care provider, the provider requested EHI from Dr. Alice that related to any new medical diagnoses and or medication treatments he's received over the past year. Dr. Alice has been treating Bob over the past year. But here, in this scenario, Dr. Alice only sent the EHI relating to new medications she prescribed Bob, but withheld the clinical data that related to Bob's suicidal ideations, because in her professional judgment, she believed that there was a significant likelihood that Bob may harm himself if his primary care provider knew about the diagnosis and accidentally or inadvertently mentioned it during his next primary care visit. So here, Dr. Alice blocked the information regarding her clinical notes on his suicidal ideation and the notes that she kept that supported that. And the reason she did that was to prevent the harm from Bob possibly hurting himself. So the information she blocked was permissible under information blocking because she was preventing harm. But she provided as much as she could. She didn't withhold everything. She disclosed the medications she prescribed to Bob, but just not the diagnosis. So the practice must be no broader than necessary. That was achieved by Dr. Alice disclosing what she could, which are the meds. So it significantly reduced the harm. So that I mean, that's the gist of the preventing harm exception. Here, I'm not really going to read much into this slide, but we intend to send these slides out shortly within the next few days after this lecture, so anyone can reference them. And I thought this table right here would provide useful guidance regarding how to approach the preventing harm exception. So the next exception we have here is the privacy exception. So its objective is that it recognizes that an actor should be permitted to provide access, exchange, or use of EHI under existing privacy laws. For example, under HIPAA, a patient must consent for the use or disclosure of their PHI. Then the actor should provide access, exchange, or use. So, however, an actor should not be required to use or disclose EHI in a way that is prohibited under existing privacy law. So, in looking at this from the opposite perspective, the unauthorized use and disclosure of PHI under HIPAA. So, say you were requested a certain set of EHI from another actor, but by doing so, if the actor fulfilled that request for the EHI and sent it over, they would be violating the privacy rule of a patient, specifically the fact that the patient didn't give consent for that specific EHI to be disclosed. That would satisfy the privacy exception. And Ryan and I have a good example here to highlight this.
Yeah. So Bob is a patient of mine. I'm a physician in this case. Bob is a patient of mine who struggles with clinical morbid obesity. I found that many of Bob's maternal relatives also suffer from the same condition. His mother Alice and his twin sister Aunt Jane were both present for, and her twin sister Aunt Jane were both present for his initial evaluation, and each provided copies of clinical evaluations from their most recent primary care visit, which included their weight, BMI, and a diagnosis for morbid obesity. I entered their medical records into Bob's EMR record as a clinical evidence for genetic predisposition to clinical morbid obesity. Bob went on and joined the Hopetown Weight Loss Clinic, a program which has certified dietitians and is overseen by a board-certified endocrinologist. They requested that I submit EHI directly relevant to Bob's clinical obesity diagnosis, which is required for all new members. So the question is, under the information blocking law, would it be permissible to withhold the portion of Bob's EHI containing Alice and Aunt Jane's clinical data, Mike?
So yes, or it would be, yes, asking if it's permissible, it would be permissible to withhold or block the information pertaining to Alice and Aunt Jane. Here, part of Bob's medical record is documentation, medical records from his mother Alice and Aunt Jane with their health data, from their healthcare providers that has their that includes their PHI, the weight data, diagnostic data, and that data was relevant, and the doctor included it in Bob's medical record because it's directly, it's pertinent to look at a genetic cause for his disease, and it's so because it's directly relevant. That would, this weight loss clinic is requiring that all documentation be sent that's relevant to the diagnosis of clinical morbid obesity. But here, you were right. You were allowed to block or withhold the portion of Bob's relevant medical record that contained Alice and Jane's clinical data, because if you didn't do so and you disclosed it, you would be violating the HIPAA privacy rule, because Alice and Jane would have to give consent in order to disclose their PHI for this purpose. Even though the purpose is for carrying out treatment, is for carrying out Bob's treatment. So Bob, I mean, he is already giving his consent, but they're not receiving, Alice and Jane are not receiving treatment at this weight loss clinic. So if they didn't consent to have their data sent over, you as Bob's physician has every right to, or you must withhold Alice and Jane's health information, or else you'd be violating HIPAA privacy rule. So that blocking is permissible.
All right, thank you, Michael. We're at the top of the hour. Thanks to everybody who could join. I know a few folks probably had to leave already. Mike, I know we have 6 more exceptions. Would it make sense to? You're welcome, Sarah. Thanks for joining us and sticking through. Mike, would it make sense to continue, or do you think we should maybe schedule a follow-up?
I'm good continuing. Sure.
Okay, we'll wrap it up, and then it'll be available in the recording for anybody who had to jump. Okay, let's go to the next one.
Next is the security exception. It covers all legitimate security practices, but it recognizes a need for flexibility. This is very similar in nature to the security rule under HIPAA regarding flexibility. So it recognizes flexibility by, one, neither mandating a maximum level of security nor a one-size-fits-all approach for information blocking practices that are directly related to an actor's security measures, and requiring information blocking practices to satisfy a few conditions. That they must be directly related to the safeguarding and the confidentiality, integrity, and availability of VHI. They must be specifically tailored to the security risks. They must be implemented in a consistent and non-discriminatory manner. And they must implement either a qualifying organizational security policy or qualifying security determination. This is more nuanced and detailed. These details are specified clearly in the statute and the guidance documents. So Brian and I have a pretty good example here to really highlight how this works.
Yeah, so I'm a physician, and my primary care practice received requests for EHI from a patient-facing app, actually, not another provider. This triggered an alert from our security IT that it detected malicious software in the electronic request. We decided not to open the request because we're concerned that the detected malware fits the profile of that which comprised 3 major health systems over the past few months. Since we did not open the request and we are not able to fulfill the EHI request, the patient is accusing us of violating the information blocking law. The patient threatened to sue us and call the police. What do you think, Mike?
Well, first of all, this is not a criminal statute, so there will be no police involvement, even though sometimes, patients can get a little frustrated. We all understand that. But that does cover an important point. There's a lot of, people often confuse, if it's a law, that must mean it's, something that's a criminal law. This is not a criminal law. So to get to the heart of this, this does not violate information blocking, because your conduct satisfied the security rule. Your blocking practice was sufficiently tailored to the security risk, which was that one instance of the EHI request. It only pertained to that request, which was directly related to safeguarding the integrity and confidentiality of your EHI because of the threat, the malware posed. And you had a rightfully reasonable belief that your electronic health data would be compromised should you have fulfilled that request. So you're good on that. That would not be information blocking. You can't be expected to fulfill a request at the risk of, compromising your entire electronic health system.
Nice. This harkens back to news headlines about EHRs locked up for Bitcoin ransom. And in fact, other than government computers, hospital EHRs are one of the primary targets for Bitcoin ransom hacking. All right. Thank you, Mike.
Next, there are a few more. Infeasibility. This is basically there's legitimate practical challenges that might occur that would limit someone's ability to comply with request for exchange, use, or access of EHI. There's 3 conditions here. Uncontrollable events. These ones are, kind of obvious: natural disasters, war, health emergencies, terror attack, labor strike, internet service disruption. Second is segmentation, meaning that the actor being requested, who received the EHI request, cannot clearly separate out the EHI being requested from that record set. I'll explain that a little more. And the last is infeasibility under the circumstances. As long as the actor can demonstrate consistent and non-discriminatory consideration of specific factors which led to its determination that complying with a particular EHI request would be infeasible under those circumstances, it would not constitute information blocking. And this must be demonstrated through a written record or other type of documentation, very specific, a detailed outline with a time frame and everything that records every instance in which a request would be too infeasible to fulfill, and as to why it would be unreasonable. This one, infeasibility under circumstances, is more of a catch-all. So that one is it comes down to you kept a record, and that record is reviewed by HHS, and if they determine it's a legitimate record of infeasibility, then you're good. The one that's a little bit more difficult to grasp is the segmentation one. So this means that when you're requested a certain set of EHI, and the EHI for that person, that specifically, that narrow scope of EHI can't be clearly and distinctly separated from other EHI that's not relevant to that individual, that would be infeasible. So for like an example of that would be this also goes back to the if we look at the example from Aunt Jane and Bob with the obesity clinic, there's some overlap here. So say that someone requested Bob's EHI relating to his obesity diagnosis. And for some reason, the way that Alice and Aunt Jane's medical records were integrated into Bob's EMR were done in a way in that it would be infeasible. It would not, it's very logistically overly burdensome to separate Alice and Jane's health data out of that record. That would be an issue with segmentation, the way that they were incorporated into his record. If it's too overly burdensome to be able to accomplish that, then you are right in withholding that information, because it actually, because your inability to segment it would also cause you to violate the privacy rule as well, and that could also this could also satisfy the privacy exception. The next is health IT performance exception. This is pretty straightforward. It's inevitable that health IT must temporarily go offline to perform necessary maintenance or enact improvement measures to ensure that the health IT performs properly and efficiently. So here on the left, I included a screenshot from a Jefferson email here, just to show like what an example of this would look like. You can see I have in red planned downtime, and it's for Epic updates and infrastructure maintenance for Jefferson Health. And these emails, I always say, look, save work now for planned downtime, because during that time period, you won't be able to access certain parts of Epic and parts of the network that store data. So here, if you were received the EHI request during this downtime, that would fall right within the health IT performance exception, because the downtime is to perform necessary maintenance. And the reason for this is that actors should not be deterred from making the reasonable necessary measures to improve health IT, even though it requires degrading its performance or making it unavailable. Next, we have content and manner. The general idea here is to support innovation and competition by allowing actors to first attempt to reach or maintain a negotiated market terms for access, exchange, and use of EHI. It accomplishes this objective by providing clarity and flexibility to actors regarding the content and manner for fulfilling their responses or requests for the access, exchange, or use of EHI. So there's the content condition and the manner condition. Ryan and I have a nice short example that clearly demonstrates how this works, that really illustrates it well. If Ryan, you want to.
Submits an EHI request via the Red Delicious Health app, which is synced to his health.
Sorry, Ryan, we missed your first few words.
Oh. Bob submits an EHI request via the Red Delicious Health app, which is synced to his healthcare provider's patient-facing EMR, MyFile. His healthcare provider does not have the technical capability to fulfill Bob's EHI request via the Red Delicious Health app. However, the provider can fulfill Bob's EHI request in an alternative manner via an online patient portal. Is this an exception, Mike?
So, yeah, well, so yes, although the EHI request was not fulfilled in the same manner as in via the Red Delicious Health app, the actor, the healthcare provider, didn't block the request by not fulfilling it in the manner as requested. They did so, they fulfilled the request, but by a sufficiently similar alternative manner. So instead of through the app, they have a patient portal online. Sufficient the tech detail wise, logistically wise, that's sufficiently similar to a health app. It's not like they're making you go, go to an imaging center to receive a hard drive with information on it. It doesn't make you have to do anything, overly burdensome. But because of that, they were able to fulfill the request for all the EHI that Bob requested through the app. He just had to do it through a patient portal. So that would not be information blocking, since the request was fully completed in an alternative means. Next is the fees exception. And this here, the overall objective is to allows actors to charge fees related to developing technologies and providing services that are intended to enhance interoperability, but it does not protect rent seeking, opportunistic fees, and exclusionary practices that would interfere with the access, exchange, or use of EHI. And we also have a short little example of this as well.
Yeah, so I'm Dr. Bob Jock, Chief of Ortho at Big State University Health System. Our EMR is Blockbuster. My patient, Alice, tore her ACL while skiing out west and had an X-ray image taken at Small Town Imaging Center, which has a different EMR system called Win95. The Win95 medical imaging file format is incompatible with Blockbuster. When she returned, I requested Alice's image files from Small Town Imaging. Small Town is requiring a fee in order to fulfill the request. Isn't this practice illegal, an illegal form of information blocking?
So what we know here is that Small Town's medical imaging software is not compatible with that of Blockbuster. So the only way that Small Town can fulfill the request is to convert the files to a compatible format. Often, when this issue arises, it's accomplished by one, either paying for a professional service to convert the files, or two, purchasing a software license for certain software that would do the converting of the files. And when you do either one of those, Small Town would be incurring a cost to do that. So they have every right to recover that cost by charging a fee that is reasonable enough to cover those costs. So it's what wouldn't be, where it wouldn't fall under the fees exception is, say it costed $75 for Small Town to convert the file, but they charged a fee of $250 for fulfilling the request. That wouldn't fall under the fees exception, because it was that was way overly way exceeded the cost of converting the files, and just kind of an opportunistic fee, because they're trying to get more money than that of which they paid for the service. So the fees must be reasonable. The last exception is licensing, and this has to do with intellectual property. Basically what this is, it allows actors to protect the value of their innovations and charge reasonable royalties in order to earn returns on investments they have made to develop or maintain and update those innovations. So this is kind of similar to like a software licensing thing, where there's a new innovative software that is used to transmit EHI, and the actor who invented it is charging or is licensing it out to another entity in order for them to fulfill EHI requests. and by doing so, the actor who's the inventor is receiving royalties from having developed that software. In that case, it would not be information blocking because they have every right to, profit from their inventions. And the government, when they make these laws, they don't want to stifle innovation. So that is it for this lecture. Right here, I just have a list of 5 guidance documents I included in the group chat that I think would be useful. And that's it.
All right. Michael, incredible job, extremely thorough. We did lose the audience at the hour, but this recording will exist in posterity to reflect your brilliance and diligence, and in honor of our new growing vendor customer partner base. If you got to this point and you have any questions, feel free to reach out to myself or Michael or or Michael, and we'd be happy to help with next steps. And with that, we'll say thank you and congrats, and thank you again, Mike.
No problem. My pleasure.